Obviously, we're going to be talking about aging and brain injury. Ironically, prior to 2005, aging was not a hot topic, especially amongst researchers. In 2005, the first published information came out about aging and brain injury, and it shocked the brain injury world to a degree. One of the things that came out of it was people who have brain injuries do not necessarily live as long as people who do not have brain injuries. Now, incidentally, this is very controversial, and some studies show this and some studies don't. But at the time, this was something to really be concerned about, because individuals who had brain injuries, who at least were living in a facility type or in a group home type setting, had a fair degree of structure, and as a result, they saw medical practitioners more often, and people thought that because their lives were a bit more in control, they would have longer life expectancies. But a lot of the studies are showing that's not the case. Now, the information you're going to see today is not entirely original. I have to say a very special thank you to Gary Seal from the Transitional Learning Center in Galveston, to Dr. Brent Mizell, and to Mary Pat Murphy and Helen Carmine. They were the individuals who made the David Strauss Memorial Lectures, and much of this information comes from that. These are the other resources, and as you go through it, you'll see I've made certain references, but I haven't made all of them, so this is to give you an idea of who these individuals are. Dr. Mizell came out with a profound concept, and that was that brain injury is disease causative. What does that mean? It means the first concept was that brain injury actually was a disease, and this raised a lot of questions. Later, after it was thought through further, it was brain injury is disease causative. Now, the reason he came out with the first comment was that because brain injury mimics the pathology of most other injuries, most other diseases. There is swelling, there is bleeding, body temperature changes, heartbeat goes up, and so forth. And it eventually was discussed at all levels, and this is the concept of disease causative came out. And as you can see, it lists over here where they say bleeding and bruising and damage, swelling, dysfunction, distress, the release of neurochemicals and hormones, specialized blood cells rush to the injury site. This is very similar to what happens with a disease. So it is a disease process. So the aging actually, it's a process that exacerbates the complications of brain injury, and brain injury exacerbates the aging process. Now, the objectives this morning are to take a look at the statistics, to pose some questions, to look at the evidence, then to do a summary, and then present some recommendations for healthy living and for long life. And you will find as you're looking at these later that they're not all that much different than what our physicians say to us if we don't have a brain injury. And then later we'll have a question and answer period during the panel discussion. Now, our population is aging. We all know this. If you're 65 or older, you're in the fastest growing segment. Ironically, I turn 65 tomorrow, so I instantly become a geriatric. Age 80, however, is the greatest expanding age population. People are living longer than they ever have lived before. So the big question comes down to what happens when we age? We begin to see our own mortality, and we wonder how long we'll live. We wonder if our health will change. Will we become disabled? How long we'll be able to drive and work and live independently? And most importantly, will we become a caregiver, or will we be the caregiver? Now, the TBI facts I'm sure you've seen many times over in presentations. There are roughly 1.5 million TBIs that occur each year. TBI still remains the #1 killer and disablers of young adults. but it also is a major killer for people over the age of 70, primarily because of falls. Now, I'm going to skip through the TBI facts just in the interest of time. But we all talk about TBI, and what we don't realize is that acquired brain injury, which TBI is part of, actually the number is twice. So when you're looking at a TBI number, double that number. That's the toxic exposure. It's the metabolic disorders. It's tumors. It's stroke. It's all of the other acquired brain injuries coming together and coming up to total twice the number of TBIs. Now, the medical issues that complicate brain injury, early onset of certain diseases. Alzheimer's, of course, is in the forefront of all of this, but Parkinson's, schizophrenia, and age-related dementia are all part of it as well. Long-term, for moderate and severe brain injury, chronic or late emerging complications in the aging process, we'll discuss in just a minute. Secondary complications for people with brain injuries are respiratory issues, fevers, infection, spasticity and increased tone, which certainly has a dramatic effect on gross and fine motor, contractures, pressure sores, deep vein thromboses. And you're probably saying to yourself, some of these are care-related, and some of these are directly related to the injury itself. From a cardiovascular perspective, changes in blood pressure have a major effect on length of age. New studies, some of which were just released in the last couple of weeks, are now saying people with high blood pressure in their 40s and their 50s are more prone to stroke when they get into their 70s and 80s. It seems to have a connection with small ischemic strokes and then with one large stroke. Now, vascular changes in the extremities, we're talking about deep vein thromboses here, and aspiration and dysphagia, so swallowing disorders, difficulty managing positive healthy lifestyles. So what we're talking about really is an individual with a brain injury is not as likely as a person without one to manage their lifestyle. And that would involve weight control, and believe me, I could write a book about that. And I don't have a brain injury. But if you're unable to plan, and if you're unable to follow a sequence, and if you're unable, or if you're unaware of the faults and falls of a brain injury, you're not as likely to take as good care of yourself. There are mobility and skin issues that seem to be prevalent with individuals as they age who have brain injury. And it has to do with spasticity and dystonia, and again, gross motor, your balance. Muscle strength and endurance, and some of you are now starting to say, at least those who are into my age group and getting a little older, well, gee, I have some of this now and I don't have a brain injury. But it seems to be more pronounced with folks who do. Diminished motor planning and inattention is on the cognitive side, and the vulnerability to falls, obviously a chance for further injury. So what do we need? We need strategy, and we need equipment updates, and we need better trained people, and we need people who understand that when they're making changes with an individual who has a brain injury, that that person with the brain injury is included, that they are part of the decision process, that they feel comfortable with it. Otherwise, it's not going to happen. There are other systems that are affected, fatigability, abnormal sleep patterns, and again, as you age, you develop, in many cases, abnormal sleep patterns to begin with. There are some new studies coming out now which are saying that sleep is when the glial cells, and you have 5 different types that are known at this point in the brain, that this is when they do their best work. This is when they do their sanitizing, and when they deliver food, and they take away waste, and they make sure that the neurons are well nourished. Without a solid 8 hours of sleep, they aren't able to do their job, and that poses other difficulties. The neuroendocrine system, with difficulties affecting sexuality, type 2 diabetes, and loss of urinary incontinence and change in skin integrity are a whole bunch of other things to be concerned about. And this goes on for the next 2 or 3 slides, just naming things that we need to be concerned about. But obviously, speed, reflexes, stress. Stress is a major factor. All of us who are still working know that family situations, work situations, socially all create an inordinate amount of stress. And stress is not good if you have a brain injury. It just simply complicates. Impaired cognition, reduced short-term memory, and of course reducing of senses, where you've got your vision, your hearing, and your sense of smell. Normal aging, excuse me. Biology changes beginning at about age 25. In other words, we start to deteriorate at that point. I like to say I started falling apart a little earlier than that, but they say 25. Psychosocial maturity at about roughly age 35. And they say social maturity peaks at about age 55. Aging with a disability begins about 10 years after the injury. And the psychosocial maturity stops at that time of injury, with social maturity being interrupted at the time of injury as well. Now, do people with brain injuries age differently, live as long as people without brain injuries, have a greater chance of developing Alzheimer's, are more likely to develop other health problems as they age? We'll get to these answers in just a minute. More questions as people age with brain injury: is emotional functioning affected? Vocational functioning different? Do people remain integrated into the community, and is quality of life and satisfaction affected? And I know that many of you in the room right now are just simply saying, of course it is. But we have some other information to give you later. So individuals with TBIs and their families need to prepare for the future. We hear this in the non-TBI community all the time. Gee, we have to save money for retirement. Gee, we have to exercise. Gee, we have to eat right. Otherwise, we will not be as well when we get older. Clinicians, case managers, and others, people who work with people with TBIs, need to be helping the individual, helping the family, helping the social network to put together a plan that works for the individual. And researchers, truthfully, aging and brain injury, they're just starting to scratch the surface as far as clinical investigation. If you look at it, since 2005 to the present is not much time. And we'll hear a little more about that in just a short while. So as far as research goes, where do TBI and aging intersect? There is practically no data out there, and it's just not well enough studied, and there aren't any real longitudinal studies in place at this point. In 2008, the Galveston Brain Injury Conference, which is an absolutely wonderful conference, and they brought in researchers from Mount Sinai, from the University of Texas, from Transitional Learning at Galveston. And they looked at 5 systems: TBI and dementia and Alzheimer's disease. They looked at TBI occurring in the elderly. They looked at TBI and life expectancy in health. And they looked at TBI aging and cognitive functioning, and TBI aging and psychosocial functioning. So, does TBI increase the chances of developing dementia and Alzheimer's? This is where it gets interesting. We would all probably say yes based on what we hear in the media, Not necessarily true. The findings were very mixed. Some of the studies suggested the overall rate of Alzheimer's in the TBI population is similar to the general non-TBI population. Do elderly sustained TBI, who have sustained TBIs, have worse outcomes than those injured at a younger age? Do they recover differently from younger people? And what factors determine the outcomes of the elderly, and do the elderly have the same rehabilitative needs, and do the elderly receive rehabilitative referrals at the same rate as those younger? And we'll have answers for you in just a second. As far as TBI in the elderly and the outcomes, in most studies, outcome was measured using the Glasgow Outcome 5-point scale, where a 1, the individual is dead, 5, it's a good recovery with the ability to return to work or school. Recovery, which is outcome, varied by severity of TBI. So if you had a very severe TBI with a Glasgow Coma scale of 3 to 8, obviously outcome would not be as good as if you had a mild brain injury with a Glasgow outcome scale of roughly 13 to 15. And to give you perspective, most of us in the room at this point are 15s. The elderly have worse outcomes compared to younger people. That's generally. For severe injuries, Glasgow Coma under 9, which is severe, a good recovery was the exception. For moderate, which is Glasgow Coma scale of 9 to 11, they had a good recovery, reported in about 50% of the cases. And for mild injuries, the Glasgow Coma of between 12 and 15, there was a good recovery in over 80% of the population studied. So, is TBI or is recovery different in the elderly? Generally, yes. Elderly tend to recover at a slower rate. They often have longer lengths of stay in acute care settings or in patient settings. And what factors determine outcomes in the elderly? Well, the severity of the injury and the age. With those over 80, often having a significantly higher risk of dying with very poor recovery. And it may not in total be because of the TBI. It may be due to other medical factors. So what factors determine outcome in the elderly? To be blunt, it's insufficient. We just don't have enough information. We do know that chronic conditions such as diabetes and hypertension, pre-injury cognitive status, fractures and internal injuries, all of these compound outcomes. And as for the rehabilitative needs for the elderly, truthfully, again, very little research. I would expect in the next 3 to 5 years we will see considerably more about this, in part because the population is aging at such a fast rate and because there will be so many more people in that population. So are elderly referred to rehabilitation based on need, and does age play a role? Well, age plays a role in decisions relative to surgeries and referral to specialized programs. There's no evidence found that indicates that age plays a role in rehabilitation rehabilitation services. So if a person who was 70 suffered a TBI, they were in a tertiary facility and were being referred to an acute rehabilitation facility, it might be the same type of referral with the same numbers as you would see in someone who might be 25 or maybe 40. So the big question, does TBI shorten life expectancy, and do people with TBI develop long-term health problems beyond what would be normally expected? Well, TBI is associated with high mortality, but that's at the early onset, and that's 50,000 individuals die each year due to the TBI. But an overall increase in life expectancy was noted for persons surviving beyond the acute injury stage. So what the studies were basically saying was, if the individual survives the injury, receives, this is a loaded statement, adequate rehabilitation, and we all know what the status of rehabilitation is these years. Insurance keeps cutting them back farther and farther. But if they receive adequate rehabilitation, their outcome for long life and for living long term is actually quite good. So those at risk for premature death, older people, people who are unemployed. And the reason for that is primarily because they're not accessing medical care, because they don't have medical insurance. Having a history of substance abuse. And substance abuse is going to compound any injury, any rehabilitative process. Now, people with TBI report more health problems than their non-injured peers. And it gives a list: neurological problems, endocrine problems, headache, vision, hearing, sexual dysfunction, allergies, and sleep issues. On the other hand, any of us in our 50s, 60s, 70s might report the exact same problems. Do people aging with TBI demonstrate cognitive difficulties beyond what normally occurs? Now, findings are mixed relative to visuospatial, but generally speaking, the population does report more difficulties. So we get to more questions. How does emotional functioning change over the lifespan of TB after TBI, and are differences in emotional functioning found in different age groups after TBI? 50% of the people with TBI experience clinically significant levels of anxiety and depression within the first year of injury. Some studies showed emotional functioning improved over time, and some studies demonstrated that the rate of negative affect was lower in middle-aged and older people with TBI versus their younger counterparts. So, after TBI is age associated with vocational success. This is returning to work, returning to school, etc. Younger people with TBI tend to demonstrate better vocational outcomes, but for older people with TBI, age is a minor factor in return to work. Other factors affect return to work to a greater degree. And in this particular situation, what is the effective age on community integration? This was all mixed results. Some studies showed that younger people with TBI are more socially integrated, and others found no relationship to this at all. And how does time since injury impact community integration? Again, mixed results. Some studies showed that time since injury was associated with better integration, and other studies showed an association with social isolation. We do know individuals who are socially isolated are going to have poorer outcomes. And I find this is one area that I've always found fascinating. Tell you a quick, not so funny story. Where I'm from New Hampshire, there is a facility known as Crotched Mountain, very well recognized nationally. They have an outstanding school for children with disabilities, very good residential program, and a very good brain injury center at the atypical subacute level. Back in the very early 90s, they decided to use HUD funds to develop 12 one-bedroom apartments with a manager living right there. And it was very strategically placed in the Portsmouth, New Hampshire area, which is very bustling and has many churches and synagogues, has food marts, and has places to buy your groceries, and has a good transportation system. And they were able to find 11 individuals who were relatively high functioning, needed some supports, but were able to manage their daily lives quite nicely. They were able to share in their resources and made things very cost effective living in this type of small community. The state of New Hampshire, I think they have recanted on this position. At least I'd like to believe they have. But the state of New Hampshire decided that they were socially isolated and decided that all of these individuals were going to move to individual apartments located all over the city of Portsmouth. So they lost their social network. They lost the opportunity to share providers and have cost-effective care. And at the same time, they found themselves in places that they didn't know anything about and didn't know how to get around, and they had to relearn all over again. And the bottom line on this was, and the interesting thing to me was, that Crotched, even though they didn't run this, all they did was develop it through the HUD funds, and the manager was employed by them. They closed it and they went ahead and they turned it over for elderly housing. So it was fine for our elderly to be, quote, socially isolated, but it wasn't okay for the folks who happened to have TBIs to live in a lovely community where they had all the supports and all of their friends. So don't get me going on government. I'm not a strong advocate. But social isolation is a major issue. And individuals who are socially isolated are not likely to get the medical care that they need. They're not likely to, or they are more likely to be depressed and to have anxiety, and they are less likely to get the resources that they need as well. So these are the reported health problems post-TBI. And if you just look down the list, I'm sure that you will recognize many of them. And I'll just leave this up for a second. The interesting thing is to note the percentages next to them. Diabetes mellitus, or type 2 diabetes, only had 1%. But sleep disorders was 41, balance 60. And as we move around, we see muscle and joint stiffness, 55% reported. Weight gain more than 10 pounds, 48%. But the most important one down below was hospitalizations, ER, and urgent care visits during the last year of 28%. We see with TBI in the aging process neglect, and we see sensory changes. We see increased frequency of seizure activity, hemiparesis, decreased trunk control, and the list goes down. From a cognitive perspective, however, we see diminished attention and concentration. Now, brain injury is very interesting. In my experience, brain injury does not get worse. You have a brain injury. There are a series of changes which take place post-brain injury and eventually reach a point of stabilization, and you start to get better. And the better the rehab, the better the support services, the better that everything comes together for you, the better the outcome. If you, and I'm having a senior moment, I hope you'll bear with me.
Not yet, Dr.
I know. What was I saying? Someone cue me. It doesn't get worse. Thank you so much. I have to tell you, cues are a wonderful thing. Something as simple as that. Yes, it does not get worse. Okay, it doesn't. It will get worse, however, if other things don't fall together. And one of the things about diminished attention and diminished concentration, your concentration should improve. Your attention should improve. Your memory should improve. If you're receiving the proper stims and your outlook is bright, you're getting good medical attention, you're living in a good environment, then you should be getting better. You may not be what you were before, but you should be getting better. So when they say that diminished attention and concentration, slowed processing and disorientation and confusion, and observations and care for seizures, and all of these things, you say to yourself, so why is this happening? Is it the aging or is it the brain injury? And that's when I would say to you that it is probably the aging and not the brain injury, but the brain injury is exacerbated by the aging process. So as all of us age and we start to notice changes, I'm driving down the road, I am in heavy traffic, and I'm driving in Florida, where people do 70 miles an hour. Keep in mind, I drive a truck, and I come from a city of 24,000 people in New Hampshire. So it's a bit different than it is here in Florida. My attention has to be very focused. If I can't turn on the radio and focus. I can't do a number of the things, the double tasking things that I used to do, that I just can't do them any longer. And that is probably the aging process. Now, add to it a brain injury, and it would be significantly different, and there would be significantly more difficulty. So the neurological issues, obviously medical, gross and fine motor, cognitive, and language, expressive and receptive, and affect, the ability to express, the ability to express with facial detail, with talking with your hands, the socialization aspect. Now, the impact on daily life as we age with brain injury is a definitive need for additional ADLs, ADL supports. There's a need for psychosocial supports. Often there's diminished participation in the community, and this unto itself can be a problem. As we age, a lot of us like to go out and volunteer and do things in the community we didn't have time for when we were working. A person with a brain injury very often gets wonderful experience being in the community, doing things that are social, that help other people, and so forth. And with the brain injury, it's less likely that they will go into the community. Some of the best programs in the country are truly community inclusive programs where you don't simply take a person into the community and expect them to integrate. You bring a person into the community and you allow them to participate in the community itself. That's the true definition of inclusion. Remaining quiet and non-involved in the home, certainly one of the problems with brain injury. Also the increased number of medical visits and the increased diagnostics. And those of us without brain injuries who are aging begin to get tired of having to go to the doctor and having to go through all of the diagnostics. So we can only imagine how difficult it is for the individual with brain injury. There's a need for increased supports with safety, with transfers. There may be nursing needs, there may be physical evaluations that are necessary. Don't discount your local physiatrist. Don't discount your local neuropsychologist. Seek out the appropriate supports for the needs for the individual with a brain injury. Now, the impacts on daily life for the person with brain injury, and again, you'll recognize these: increased impulsivity, increased memory impairment, except both of these could be with a person who's simply aging who doesn't have a brain injury. Decline in problem solving, same thing. Poor frustration tolerance, oh, believe me, there are days when I have a very poor frustration tolerance. And then, of course, decreased awareness and limitations of safety, which was one of the big factors. And then there are, of course, poor carryover strategies, neurogenic bladder, dysphagia, GERD. The strategies, well, there needs to be a strategy for safety. If there isn't a strategy for safety, a person becomes unsafe, persons will most likely sustain another brain injury, a second or perhaps even a third. There's a definitive need for PT and OT and sometimes speech pathology. As the individual ages, a good old-fashioned go out and visit the local physiatrist and get a thorough evaluation. He or she may script some OT and PT, go and visit with the OT and PT and find that there are a number of things that can be improved. And if you can maintain the improvement and maintain a specific level of ability, that the individual with the brain injury will do significantly better. Speech and language, everyone thinks of speech pathologists as being only for dysphagia, swallowing difficulties, and for speech, for phonation. And yet they do so much more. All of the areas, OT, PT, speech, and certified therapeutic rec specialists all do cognitive work. But I find that speech pathologists are really out there doing some of the leading edge cognitive work. Certainly psychology for frustration and impulsivity, neuropsych for testing, but also for identifying deficits, and this is what people fail to realize, is that a neuropsychologist can help identify those hidden factors, and if they're able to identify them, they can then develop strategies for improvement. Physiatry, neurology. Physiatry has come a long way. It's a relatively new field, but they are physicians of physical medicine. They deal primarily with the disability community. And there is a new certification coming out. It's actually a subspecialty. And I don't know if it's actually hit the streets yet, but it's about to if it hasn't. And that's for physiatrists to become specialists in brain injury. And it's also for neurologists. So you will start to see these subspecialties. And that should also make a significant difference for our aging brain injury population. Now, the 10 steps to healthy living. And you'll say, oh gee, this isn't typically just brain injury. This is for all of us. Take good care of your heart, eat healthy. Exercise the body, stay moving. Well, you stay moving for two reasons. One, it keeps all those tiny little cells moving and allows your protection systems to work, your immunity systems. But it also helps with weight control, helps with strengthening. It helps with fine and gross motor. Then exercise the brain. Everyone hears about neuroplasticity and everyone has a different definition of it. And everyone goes out and they buy a book that allows them to do this puzzle activity, and then they watch a video that makes them think about this. And there's a whole new budding industry out there. And I don't really have an opinion on it except to say it wouldn't hurt. So probably a good idea. Maintaining a high level of activity, maintaining a high level of socialization, all of this is cognitive. Everything you do is cognitive. So the more you can do, the more your brain is going to maintain its plasticity. The brain has to be exercised. If it isn't, it will atrophy and not work as well. Feed the brain, diet. Everyone says, oh gee, you've got to watch out for the heart. Well, you absolutely do, but you have to watch out for the brain too. Promote good mental health, reduce stress. And as far as avoid toxins, ETOH is an old term for basically for alcoholism or alcohol abuse. Illicit drugs and tobacco products. Better than 50% of people with brain injury, according to the CDC, have some type of a reliance on either alcohol or on drugs. If in the recidivism numbers actually are fairly high. A person has some drug involvement, they have a brain injury, and then, excuse me, they no longer have a drug problem, but they begin to develop a drug problem again. So supports for each of these toxic substances are imperative, and it will make a significant difference. Avoid social isolation. We've talked about this. Protect the brain, avoid future injuries. People who have had a TBI are at much greater risk of having a second and sometimes a third TBI. Form partnerships and supportive relationships. No one can do this alone. And as many of you as caregivers know, it's very, very difficult being a caregiver and taking care of a loved one, and in part because you are so close. It's stressful. You become the individual who has to find all the strategies. Start looking for other resources. And you need supportive relationships as well. Now, families look for greatness in both the survivor and in the care provider. And there is certainly greatness on both sides. Working with a case manager, and not everyone has the opportunity to do this, but case managers can be a terrific wealth of experience, mostly if they have a background in brain injury If they don't have a background in brain injury, my suggestion would be look for a case manager who does. Case managers are usually very well-trained people, and they have a lot of capacity, but brain injury is very unique, as we all know. And if that knowledge isn't there, the help probably won't be there as well. Obviously, family education is of major importance, and you need to develop mechanisms for ongoing assessments and the coordination of care. And when we get into this, all of us, as we reach a certain age, begin to see our own mortality. And we start to say, gee, I've heard that I should have something called a durable power of attorney or a healthcare proxy. And yeah, I probably should have advance directives, and yes, I probably should have a will. And it usually takes some type of stressful situation in the family before most people realize that they have to do it, and they have to do it now. Often, people with brain injuries don't have these. So find the resources and ensure that the people you're caring for do have a will, that their wishes are known in the event that they're unable to manage their own care or make their own decisions medically. And certainly know what their wishes are and have them in black and white and have them with your medical provider or their medical provider so that those wishes are known in the event that the individual is unable to make any decisions and is in a situation of end of life. So there are special considerations. With early dementia, requires an increase in care and support, and we want to plan for day-hab options. We want to look for durable medical equipment, multiple resources, and equipment that they truly can use. And find and utilize health and strengthening programs and to prevent social isolation. Now, mental health is one of the big concerns. Suicide accounts for almost 2/3 of all TBI firearm deaths. ABI increased the lifetime risk of depression by 54%. And mild TBI increases the risk of mental illness, usually within 6 months. But most importantly, depression affects successful aging. It reduces the quality of life. It increases the risk of cardiovascular disease and other diseases, neurodegenerative, such as Alzheimer's. The following people with TBI are at greater risk for developing Alzheimer's, to answer one of these questions. Males, those with more severe injuries, and those with repetitive injuries, and those with pre-existing genotype APO large E4. The elderly do recover at a slower rate. Their recovery depends upon severity of injury, and people 80 and older do have a higher risk of dying and have poorer outcomes. The life expectancy and health after TBI, some people with TBI are at increased risk of premature death. People with TBI reporting more health problems, those who are older at the time of injury, unemployed at the time of injury, have a history of substance abuse, and younger persons with immobility, swallowing problems, or infections. Now, the post-TBI aging and cognitive functioning, the findings are mixed for memory and visuospatial functions, as mentioned. Processing and motor speed may increase over time. Executive functioning may improve over time, and that's dependent upon age as well. As far as psychosocial functioning and aging after TBI, depression may resolve over time. Older people with TBI report less negative emotion. Age may not be a factor in vocational success. Mixed findings regarding community integration, as with many other things. And age at the time of injury may affect life satisfaction. But at the same time, positive psychological growth may occur with our aging population with TBI. So we get into Recommendations. We want to create a structure. We want to have consistency in our everyday life. We want to use external compensatory strategies. We want to safeguard against stress. We want to eat healthy. We want to eliminate alcohol and tobacco. And we want to get lots of sleep. We want to exercise 3 to 5 times each week, preferably anaerobic and resistance types of exercise. We want to set goals to challenge the brain, increase our plasticity. We want to be aware of medication side effects and contraindications. And another reason for regular medical visits, and also a good reason for a visit to your physiatrist, is to make sure that the individual who's aging with brain injury isn't on too many medications and is on the appropriate medications and the appropriate dose. You want to take advantage of social supports. You want to practice positive emotional feelings. This is the beauty, the meaning, and the purpose of life. And in conclusion, Dr. Mizell said brain injury is not a short-term condition. It is disease causative, and it's chronic, and it requires many services and supports over the lifetime of the individual. So that concludes this. Be glad to answer any questions for you when we come to the question and answer period.